Hi, everybody. Welcome to today's webinar looking at interoperability. Just give everyone a few minutes to join the call, and then we will get started. If whilst we're joining, you want to introduce yourself in the chat, that would be really lovely, so we know who we've got and where you're from. So do say hello, and we'll get going in a minute. Thanks, guys. Hi, everybody. Welcome. For those of you who didn't hear me just now, welcome to today's call. I think we will get started with intros in just a minute, but do introduce yourself on the chat. We'd love to know where you're from, and who's on the call with us. Thank you so much. Okay, whilst you're all doing that, I will get cracking with introductions, and then that gives us more time for chatting and Q&A and things later on. So, as I said, so with Digital Care Hub, my name is Fiona Flory, and I'm one of the engagement managers. And today we're looking at interoperability in social care, and sort of how that links from national policy through to actual care delivery. If you haven't seen, this is part of our digital care in focus topic for this month. So we have a whole suite of different resources available all around interoperability, sort of giving sort of insights, news articles, etc. So do have a look on our website if you haven't seen that already. So just a little bit of housekeeping. If you haven't seen already, we are recording the webinar, and this will be available for you to view afterwards. So if you wanted to recap on anything or share it with colleagues, it will be available. Attendees, you are all on mute and we can't see you. So please do have your lunch, have a cup of tea, and take a moment to replenish whilst we're doing the webinar. What we would love, though, is for you to engage with us. So please do use the Q&A function for any specific questions. This just enables us to manage them a bit more easily behind the scenes. If you're just making a statement or general chat, please use the webinar chat that you're using at the minute to introduce yourselves. Oh, Esther has just said she can't hear me. Can everybody else hear me? Okay, so fingers crossed, it's just an issue with Esther internally, and hopefully she can get it sorted. Great. Thank you for everyone who's confirmed that they can hear. So yeah, please do use the chat for general chatting, use the Q&A function for actual questions, and then we can field those to the right person at the appropriate time. We will send you the recording along with all the presentation slides after the webinar and any other resources that we think might be useful. So if things come up in conversation, we'll make sure we share those with you. So please don't worry about making reams of notes unless you would like to. So just to introduce ourselves, as I said, we are the Digital Care Hub. We're a national not-for-profit organisation, and we support the social care sector to embrace digitisation, adopt digital technology, but most importantly, to do it safely. If you haven't come across us before, do take a look at our website. We've got loads of resources and things on there for the care sector. Okay, so what are we going to be talking about? So obviously I've just done a welcome and housekeeping. Oh, Helen's saying it's really distorted. Is that the sound or the image? Sorry, Helen. Gotta love a tech webinar where all the tech goes wrong. Wouldn't be the same without it. Both fine for me from Eleanor. Okay. Anyone? All good. Okay. Helen, it might be something to do with your end because it sounds like it's okay for everybody else. But do let me know if there's any other issues. Okay, so we are really lucky to welcome a great panel of guest speakers today. Kicking off first, we're going to introduce Tommy from the Digitising Social Care team. He's going to give us an introduction to sort of interoperability and how that looks nationally, what's happening with regard to policy and investment at a national level. We've then got two really interesting case studies of interoperability actually in action. So Dan Heller from the London Care Records team is going to touch on their experiences, and Alex from Dorset Council. And this will be a real opportunity to hear about actually what's already in place, how it's worked, but most importantly, actually what some of the challenges have been and how they've overcome those challenges. We're then just going to do a bit of full circle and think about actually as care providers, what can we do now to prepare or to consider moving forwards as interoperability advances within the sector. And then hopefully we'll have plenty of time for Q&A and other discussions towards the end. So just before we get going, I just thought it might be quite nice to actually think about actually what is interoperability. Um, I took this definition from NHS England, which pulled out that actually it's the capability for people involved in the provision and receipt of care to interact and complete a task across software and organisational boundaries, and use systems from different vendors that work together in a coordinated way with minimal human intervention. Whew, that's quite a mouthful. But actually, I thought that the little bit underneath, I took actually from one of our Digital Care Hub articles, and I thought it just made it come to life a little bit more and saying, actually, it's about joining the dots. It's not about duplicating things. It's not about necessarily changing systems, but actually just making sure that things talk to each other, they connect, and actually that reduces duplication. It avoids gaps in information, and it enables us to all work with the same basic understanding. And I think what's really important is then making sure that that service user experience is improved as a result. We can deliver better care and they can receive better care without having to repeat the same thing 500 times or tell everyone the same story. And I just thought it was quite nice to start with that as a thought, but actually what is it and what does that mean for our care organisations? But I'm going to stop there and I'm going to pass over to Tommy, who will give us his thoughts on interoperability. So welcome, Tommy.
Thanks, Fiona. What a good definition. And I think before the slides go on, I think my thought for the day that I think the takeaway is that interoperability begins with people. It begins with the ability of us as individuals to connect with other people. If you're in relationship and connection with people in different organizations, the likelihood of interoperability becoming more fruitful, or should we say successful, is higher than if you don't know and are disconnected. I think that's just a basic human thing. Not technical at all, but my observation would be that's the case. So the reason I come with that reflection is that I am a social worker, and I've been a social worker for quite a while, and I've worked in different settings, be that for care providers or specifically not-for-profit care providers in the NHS, and children's and adult social services in lots of different forms. And interoperability has always been a headache. Okay, so I want to caveat everything that is said from my perspective in my little slot is that I don't have the answers, funnily enough, and I don't claim to have the answers. It is very complicated, as we all know, and we have been and continue to talk about interoperability for quite some time. It is a complicated landscape. There are many moving parts to it, and as a result, things don't happen overnight. But I think in understanding our role, your role, the significance and impact positively that can have, compared and connected to our colleagues in different parts of the health and social care and housing and probation and voluntary and beyond sector, we move closer towards understanding a little bit more about what our role could be towards making the context for the people we support a little bit better, and how interoperability helps with that. So I thought it would be helpful to try and give a little bit of a perspective as to what the program Digitising Social Care as a program is doing, trying to enact some of the government desires and commitments around interoperability, and what does that mean for those of you on this call today in your wide and different roles in the social care sector. So could we move to the next slide, please, Fiona? Sorry. So where we are now, well, thanks to the organisations across the country, all 18,000 or however many individual care provider organisations there are in the country, we now, according to the CQC, think that more than 80% of care providers are using a digital social care record, electronic care planning, or DSCR as the more recent zeitgeist acronym has come up, DSCR. Now, that doesn't mean that all care providers are using the same software, as you'll probably know, and that doesn't mean that all care providers are using inverted commas off the shelf products. Digital social care record could be Excel spreadsheets. Or it could be an off the shelf product that you probably know from the many roadshows that exist across the sector. So I want to clarify that by 80%, we mean 80% are using a non-paper based form of intervention. What we have also done as a program is say to the market, so the providers the suppliers that would provide off the shelf products, is if you can assure yourselves against a certain set of standards that are in the hyperlink that you can look at afterwards or on our website, if you assure yourself against those standards of performance, connectivity, functionality, market management, contract management, then you could become an assured supplier. And that helps us create a template, to use more simplistic terminology, that would allow purchasers of that technology, i.e. you as care providers, to be able to move closer to what we would think about as interoperability, the ability for your template, your system, your software you use to, if I hold that handout like that, to be able to connect to the template of another organization that might be in another setting. By having set clear standards, you're able to create a template. If you don't have clear set standards, you can't create a template. So that's what we have tried to do. Thus far, before we had done that, the market didn't have that. So we now have a position where there is a part of the market that is more closer to having a template, to moving towards some more closer defined semblance of interoperability.
Tommy, sorry, just to pause you. Somebody in the chat's just asked if you could repeat those standards, if possible.
Oh, well, the standards, there are many standards. But in essence, it's around performance, what the system does that you're purchasing, what functionality it would have, A, for you as a purchaser of that, but B, what it could do and connect with other things. So as an example, if a supplier wants to be an assured supplier, it has to have the ability to use GP Connect to be able to connect to GP care summary records. So in terms of functionality, and equally to be an assured supplier, what the standards are in terms of your procurement, i.e. cost, bare minimum functionality for costings and so on and so forth around contract. Those are the very brief headlines. There are many detailed terminology statements within that hyperlink that you can look at on the Digitising Social Care websites. But that's the headline that I would go for so far, Fiona. Can we go to the next slide, please? So now that we know that a significant proportion of the market are using assured solutions, not all, but a significant proportion are using assured solutions, what do we do next? We also know that a lot of care providers and a lot of local authority commissioners and NHS commissioners think about the use of care technology as well. So you've got devices, Internet of Things and care technology, care tech, telecare, as it's often called or sometimes called. But we don't have any standards for those technologies either. They are increasingly important and people rely on them for their care and their care outcomes and quality of care that they experience. But we don't have any set standards as to performance and what they should be like. So we're looking at national standards for care technologies. And equally, how do we join up data? Increasingly, government is aware that the data that you as care providers record on a daily basis, hourly basis, minute by minute basis are profoundly important for the outcomes that people experience. You have a significant role in shaping commissioning. And equally, when we think about the NHS 10-year plan, although it's disappointingly not mentioned in any great detail, the role of a care provider in neighbourhood health is absolutely integral. And therefore, the data that you potentially house or record and capture has a significant impact in shaping the reality. Creating a 3D picture rather than a 2D picture, to use a rather rubbish analogy. And the idea of care providers being fully digitised is something the government is really interested in. And to be fully digitised, the government would consider to be using an assured solution that we have assured with the sector, and you're fully compliant with the Data Security Protection Toolkit standards met. And I think we'll come on to that at the end, but I think those are pillars that I think are really useful to think about in terms of interoperability. Next slide, please, for me, Fiona. So what are the emerging problems that we see? None of these will be new to you, but I think it's important to talk about them. So these are some of the headaches that we come across nationally, and I'm sure in your own individual settings you might recognize some of these, or there might be more nuanced regional versions of that. But what we see nationally is that data exists all over the place, frankly. And the data that care providers and local authorities capture isn't fully standardized. It's nuanced and it's regional. It's not always consistent. And therefore, the national view of activity and data is very patchy. It's a pretty ineffective sieve, if you want to use a culinary analogy. And therefore, this comes as no surprise, and has been the case for myself as a social worker, and I'm sure is the case for all of you on this call, is that data across the sector isn't joined up. If you want to move between suppliers, it's a real headache. If you want to find out what's happening from the GP or from acute care or from any other sector, whatever that might be, it isn't straightforward. And therefore, that means that there's a significant disconnection, and therefore there's duplication and delays for the people we're trying to support. And if that person has a series of conditions that are complex, physical, mental, connected, the outcomes of that they experience aren't fair, really. It's not fair, is it? And it's in stark contrast to the reality of the situation for banking. So if we could do it for banking, why can't you do it for health and care? And there are many reasons why the situation is the way it is, but that's what we observe. And so what we have seen to date is that there are, I'm sure many of you are aware, shared care records, and some of you may have some interactions with them, some of you may not. That would be interesting to know at the end of this little slot, at the extent to which you're involved with that. But there are 42 shared care records across the country, which is complex in itself, as I'm sure Dan and Alex will attest later on. But what we're seeing to date is that, quite understandably, each one of those 42 ICSs that host the shared care record or are connected to them will say to the suppliers of digital care records, care planning, well, we know that you're standardized and we're looking at interoperability. We see and understand the value of social care data. How can we connect? But the cost for each supplier to connect with the health and social care network, the HSCN, that would connect to a shared care record is about 10K a year. So that's a real headache for a supplier as to how to navigate that. And then if you think more broadly around the federated data platform, single patient record, GP systems, there are lots of moving parts to this. There are many plates that are being spun. So if you think about the picture on the right-hand side, we have this hypothesis and we want to test this. And I'll go on to that in the next slide. We want to have this hypothesis that potentially a single point of consolidation that would connect health and care data might reduce interop, is the short term for it, interoperability burden. And maybe, and think about increased security, which is obviously a key thing that Digital Care Hub are thinking about. Next slide, please, for me, Fiona. So we are thinking about creating the SCIP, horrendous acronym, but we are where we are, Social Care Interoperability Platform. If anyone has a better acronym, please do let us know, because we haven't come up with one. But we want to think about the idea of how you can facilitate data sharing across care and with health. I'm very conscious that as a nice to have is something that's been highly elusive for as long as health and social care has been in existence. I know that experience personally as a social worker over many, many, many years. We want to give people the opportunity to access the right information to support people when it's needed. So in order to go about working out how to potentially complement and support a positive move into this space, we need to go into a phase what we call discovery. Because we're using taxpayers' money, we have to evidence how we're doing something and the coherency and transparency around that. So I have a very clear idea as to what should happen, but that's me personally from my experience. We haven't tested that idea. So what we're doing at the moment is discovery and testing that idea as to what the SCIP, what the social care interoperability platform could look like. Next slide, please. Fiona, thank you. So why does it matter? Some of this is obvious, but some of it needs to be drawn out, I think. Personalised care plans tell a person's story. And wouldn't it be great if information about that individual, their nuances and personal preferences travelled with them when they moved into different settings? Wouldn't that be honouring of the person and aligned with the values of the organisation you work for? But that's not the case at the moment, or not often the case. If we think about the reduction in clinical risks, I mean, you could take the word clinical out, or you can define the word clinical as you wish, really, but the reduction in risks and harm to individuals and the staff that are accessing that information. Think about the efficiency and cost reduction. I talk about cost reduction not in terms of the amount of money that is proportioned to the sector or to organisations through block contracts or through private purchasing. I don't want to. That's not what I mean here. I mean in terms of, if you think about the cost of a delayed discharge or a failed discharge into and out of hospital, it costs everybody. It costs individual emotionally. It costs you as an organisation time. It costs the NHS. Everybody is losing. But we also know that integration and interoperability has the opportunity to think about better data-supported insights, reflecting on what's happened and understanding what activity might be better in the future if you did it slightly differently. If you know now what you didn't, if you know now what you knew then, in hindsight, you might have done things differently. You might have put whatever money you've got in your organisation into this area as opposed to that area. It's a point of reflection, and if the resource allocation is highly pertinent and very relevant to all of us, particularly for those of us who are care providers. Next slide for me, please. Oh, actually, sorry, can we go back? I just want to check that thing on the left. Sorry, Fiona. So just to clarify that when we're talking about the social care integration platform, we are not talking about something that will replace shared care records, by the way, and we are not talking about something that will replace or will do what your current electronic care planning, your digital social care record will do. Okay, it's not talking about storing information, and it might in the future think about providing an analytics platform to some degree, but that's quite complicated. And depending on the GDPR nuances, primary or secondary usage, we would need different legislation. That is down the line, but a potential form of positive fruition that might come from it. Sorry, next slide, please. Now, Fiona, just testing your skills. So what could further use cases for the social care integration or interoperability platform look like? And I'm sure that these might all resonate with you. But I'm really conscious that hospital discharge is often the zeitgeist, but there is much more to a person's individual story than in and out of hospital, particularly if, let's say, that person is a working age adult with long-term conditions and requires care and support in the community. Their interaction with the hospital might be as irregular as mine, so that's not everything, but we do know that hospital discharge is a significant pain point and has been a significant pain point for many years. But also we know that people come with complexities and moving parts. So for example, 3 weeks ago I knew of a colleague who was supporting someone who was non-verbal, who hated strip lighting, who really hurt their arm in their placement in a charity shop. They slashed their wrist on some glass that came off the shelf. Their care plan said that they really don't like loud noises and strip lighting and find it very difficult in such scenarios. But of course, guess what? Because of a lack of interoperability, that nuanced, really important information about that individual was lost through being picked up at by the ambulance and taken to A&E, and was thrust straight into a loud, acute A&E setting without any mental health nurses on the rota at the time. And that individual really suffered as a result of that and has a significant stigma about hospital as a result. But Could you therefore create some technology that would potentially alleviate that? What about the idea of predictive analytics and resource planning? And equally pertinent to all of us is safeguarding is a real concern. It is a real issue. It is a live issue for many people. And we do need to be cognizant and aware of that and how those factors and themes are interwoven to the reality of people's care experiences. What about eligibility checks? If you know that the local authority has ascertained X, Y, and Z from their care needs assessment and beyond, do you need to do the same thing? Maybe you do, maybe you don't. I don't know, but it's something that we're thinking about and ruminating on. And actually, could we down the line create technology where the individual themselves and their family members and carers, with the correct protocols in place, have much more of an access to their care and have a say in how that's shaped in a way that might not be the case at the moment? Next slide, please, for me, Fiona. So it could enable connection to the single patient record. Imagine the NHS app has some connection to social care data in it and providing a holistic view. Imagine technology that connects neighbourhood health connections that are connected to speech and language therapists, to community psychiatric nurses, to physios, and so on and so forth, in a way that it doesn't currently exist. Could we think about how we can support local authorities and how they currently submit data to central government around activity? Could we think about how care providers submit information around the capacity tracker and so on and so forth to central government? And could we think about secondary use data to think about anonymized activity? So that would be, you wouldn't be able to attribute that to a person, but understanding anonymized data to understand the actual activity and actually understand the reality of the situation of what it is to be a care provider and how absolutely integral they are to the outcomes for community health. Next slide, please, for me, Fiona. So we're doing some user research. If that's of interest to you, I'll put my email in the chat and please get in touch. And if you have any connection with district nurses, that's a particular demographic that we are trying to talk to at the moment. So if you do have or are connected to our OFA with district nurses in your area, please, I'd love to have a chat with you afterwards. Next slide, please. Conscious of time. Anyway, I'll move past these. And
Don't
people
worry,
can see.
Tommy, if it's anything critical, I've got a buffer, so.
Okay, so the in summary, the main areas that I would say here is that what are we doing to start with? This is what this slide is. What are we doing to start with is, if you are an organization that's purchased a software from one supplier and you find that because of whatever reason you want to move to another one, that is a real headache. And you've got to continue the care that you're providing whilst changing. And if you had any hair, you might lose it due to stress at the moment. It's a nightmare. So how can you create a protocol where you could move between suppliers with more ease than it currently is the case? We certainly know that certain care providers who may have digitized maybe 6 or 7 years ago want to move in a different direction, but that maybe not they don't have the appetite to think about or resilience or funding or knowledge to be able to move to another one, even though they'd like to, because it's such a headache. Could we help the transfer between providers? And equally, we don't have a unique identifier for individuals in society as a whole. And this isn't a comment about big brotherisms, but the closest thing we do have at the moment is the NHS number. And there are potential pitfalls to some of that. But at the moment, if we think about the connectedness across care for children in the NHS and in children's social care, and care for adults in the NHS and in adult social care, the NHS number is as close to an identifier as we've got. And if you haven't got an identifier, it's very hard to deliver direct care and therefore interoperability more broadly. So the matching of the NHS number and that functionality across the system needs to be better than it is. And those are the two things that we've observed at the moment. Next slide, please, Fiona. So what do we do? Do we do nothing? Do we build from scratch? Do we wait for a national program, or do we think about reusing and connecting to existing interoperability platforms? Our current thinking is the last one, because if we built from scratch, that would take forever and is potentially a duplication, whereas we do think that there is the ability to connect to existing infrastructure as it currently stands. Next slide, please. So this is my final slide, coming in 1.5 minutes overdue, but here we go. What could your role be in all of this? I've talked quite hypothetically with an alluding to some real life scenarios that you may or may not have resonated with. But if you're not using an assured digital solution, you're not in the game effectively. Your story, the data you're capturing for your residents, wouldn't meet the standards for the Social Care Interoperability Platform. It probably might not be that. It would be considered centrally not that safe. Now, whether you agree with that or not, that's not my call really. But you do need to think about what it is software you're using. Are you even using a digital solution? If you are, is your solution assured? And are you DSPT compliant with standards met? And if you're not, then you're not in the game either. Because interoperability is a two-way street, and you need to show your credentials around safety, awareness and trustworthiness and governance. And I don't doubt that that is something that you're all aware of, but I think what we would observe centrally is that we have the option for GP Connect, where care providers can see read-only of the care summary record. Now, that is not a perfect window of interoperability, but it is the best function that we currently have. We know that there are more than 18,000 providers, but we can't estimate more than 4,000 providers using GP Connect. So there is a significant disconnect between that potential functionality. We don't quite know why it is that the vast majority of care providers don't take that up, whether that's because they're not DSPT compliant, they need to be, and whether they're not using an assured solution. There are many reasons why, and the plight of the care provider has for many years been very difficult and is as difficult now as ever. So I don't underestimate that. But from an interoperability perspective, the care provider role in neighbourhoods and integrated care is profound, really, and your story and your connection to that is profound. And actually, your ability to shape national data collections could be seismic if you're using an assured solution and if you're DSPT compliant. So I will stop there because we've got Alex and Dan who've got a lot to tell, and I need to stop talking, frankly. So I'll stop there and pick up any questions in the chat whilst it is
Thanks
carrying.
very much, Tommy. Really great introduction and brilliant to hear what you're up to. We've had some really nice engagement in the chats. There's a couple of bits that you might want to respond to with people wanting to connect, which is brilliant. And the actual specific questions we will pick up at the end, sort of alongside any questions from the whole session. So thank you, Tommy, and thank you guys for engaging in the chat. So I would love to pass you over to Dan Heller. Now, Dan, I'm sorry, I've opted out slightly and just put London Care Records Team, and I appreciate that is not actually your job title or your employer, but I thought it was maybe slightly clearer to our audience
No,
who you are. So Dan is going to talk through their experiences in London of sort of what they've done sort of already around interoperability, and so we can hear sort of their story and learning points. Now, Dan's not got slides, so what I'm going to do is stop screen sharing so that you can actually sort of look at Dan rather than a random blank slide, and then I will share slides again in a minute. Thanks, everyone.
Cool. Thanks, Fiona, and thanks, Tommy, as well. That was really helpful, and I'll try and kind of build on some of what Tommy said and kind of bring some of what he's mentioned to life, and in terms of how it works in London. Yes, also apologies, I don't have slides, but yeah. So I'm Dan. I work for NHS England, and I work in the London region. And the team that I'm part of is called Health and Care in the Community. Now, the idea of that is that it is really about it's about health and care, and it's about by in the community. I guess we kind of mean not an acute hospital necessarily. So my specific role is around supporting social care providers to access information or be interoperable digitally with healthcare information. And I also kind of have a bit of a remit looking at basically the same, but for community healthcare services. So, Tommy, when you were asking about district nursing, actually, a lot of the challenges that you framed for social care providers, a lot of frontline community healthcare staff also say that, we can't access the information we need. Happy to have a chat with you about that offline and the district nursing question. But so yes, I'm Dan, work in the London region, and I'm going to tell you a bit about how we're trying to help and are helping social care providers to access healthcare information to support their interoperability journey. There are a few different ways in which they can do that in London. So the main bit that I'll talk to you about, because it's the main bit of what I do, is trying to connect care homes in London to the London Care Record, by which I mean that staff, a select number of staff in those care homes, will be able to see the London Care Record. The London Care Record is the regional shared care record system. And we've been working for quite a few years now, from the idea being hatched about 4 years ago to now, and we've got about 300 care homes connected to the London Care Record, which means that 300 care homes in London, or staff in 300 care homes in London, have the ability to access the London Care Record. We think on a regular basis. Our most recent data has been a bit, we've had a few issues with our data, but we think that approximately 60% of those care homes that have access are actually genuinely accessing it on a regular basis. And we think that out of 1,250 or so care homes in London, our kind of maximum window, a maximum number of care homes we'll be able to connect to is around 600 or 700 care homes. So that gives you a bit of a picture of where we're at. Now, the reason that I'm not coming to you saying we're going to be able to connect all 1,250 care homes in London to the London Care Record is because basically it's down to funding and the way that this work initiated. So before I delve into exactly why that is, the first kind of key takeaway I was going to share with you is that progress is really messy, and almost, looking back at where we are now, we've almost kind of built in inequality and kind of different levels of access, and whilst that's something we're looking to resolve and trying to kind of stay in touch with Tommy's team to help them with the social care interoperability, hopefully to kind of resolve that, we completely recognize that the way we've gone about it has created some inequality, and we want to try and resolve that. So anyway, back in COVID times, when care homes were in the news basically every day, we in the London region we accessed some funding essentially that was to be used to support connecting the London Care Record, connecting care homes to the London Care Record, and that after some initial discovery work and research, the decision was taken in London that the best way to do that was via an in-context link through one of the DSCRs that Tommy's been talking about. Each of those DSCRs essentially sort of required a development fee for us to create that integration. And so the decision was made that we'll kind of take 5 of the top suppliers, work with them so that the suppliers that give us the biggest market coverage, and then let's see where we get to, whilst we also kind of support system engagement to actually reach out to care homes and work with them to get access. A few years down the line, we don't have any more funding to connect to more digital social care record systems. And as of this week, we are connected with 4 out of the 5 digital social care record systems, and we're so close to being connected to the 5th. But I've also been saying that for a long time. So yeah, it's been a bit of a journey. Each integration with one of the DSCRs has taken a long time. It's taken a lot of work from the One London team, who are the team that kind of run the London Care Record. They have put a lot of time and expertise into, resolving teething issues, supporting the DSCR suppliers through that process, hand-holding the first couple of care homes per supplier that have tested it out, and working out what the issues are, what are the things we need to, the gaps we need to plug, refining the kind of system support process so that if a care home connects and says, we've got an issue, we can go back and make sure that they've got the right access. So anyway, that's the London Care Record, and I'll pause there. I'll come back to it. A couple of other ways that social care providers more generally in London can be interoperable. So we have something in London called the Universal Care Plan, the UCP. It started life as an end-of-life care planning tool. It now has a lot more functionality. So it also has long-term care planning capabilities for lots of different conditions. The way we like to summarize it is the London Care Record looks back at, and again, as Tommy said, it kind of tells the story of someone's condition, but also their care so far. The Universal Care Plan is a plan, so it's looking forward. And any social care provider in London, as long as they meet those kind of security requirements, particularly the DSPT, so they have to be DSPT compliant, but they can get access to the Universal Care Plan either via a web portal link, or if they're a care home that has access to the London Care Record, they can actually just click into it via the London Care Record, which is obviously much better because it saves them having multiple logins for different systems. So we've got that. We've also got, on a much probably smaller scale, but there are handfuls of particularly care homes that have got access to particular remote monitoring systems, where those monitoring systems will send information back to the GP. And actually what we have sometimes is, just to take an example, a care home that uses PCS as their DSCR, and they have, I think, Febris remote monitoring capability in the home. They can check on the London Care Record if the Febris information is getting through to the GP by logging on to the London Care Record and checking that everything's kind of flowing the right way. So there are a handful of different ways. So we know in London that there's about 500 care homes or so that aren't going to be able to get access to the London Care Record at present. We also know that of the, say, 400 or so more care homes that could get access to it, about 100 of them, possibly more, just aren't interested, don't want it, don't want to know. And that's for different reasons. And generally it comes from two ends of the spectrum. So there might be from a larger care provider, one of the big national care providers, who perhaps might think that, if we connect these 20 care homes to the London Care Record, we'll also have to connect, 15 care homes to the Greater Manchester Record, homes to the Cornwall Record, all the different records. It's a lot to manage. If there is anybody from those massive, large providers on this call, I would just say the benefits are unbelievable to having access. And yes, it may be a lot of work at kind of head office level, but in terms of time saved, in terms of better information, it's just unbelievable. And I'm happy to connect. I'll pop my email address in at the end of this in the chat. I'm happy to have a chat about what the benefits are and why the kind of effort required at head office level is totally worth it. At the other end of the spectrum, the smaller care providers that basically don't have the kind of capacity or the headspace for following the small number of steps that are required to get access to the London Care Record, or don't feel like they're digitally mature enough. So it's worth it, again, because ultimately this will save staff time, and B, there is support available in the London region to help people to, help providers to get to that point. So yeah, I'll put my contact details. So in terms of challenges, I've just mentioned one, so that kind of convincing people to get on board. We've managed to get 300 care homes on board so far, and the feedback that we get is really positive. We opened up the scale up of in-context link access after a successful pilot in about 30 care homes, and we had an evaluation and across several measures, including kind of time saved, working relationships with other bits of the health and care system, and access to better information, it was deemed a success. You do have to, we have to maintain those relationships with the digital social care record systems. That's fine. At times, it took us a while to get to a good place with some of them, but because actually once we've paid the development fee, and they've done the integration, it's just there. It's not necessarily a priority for them, and we recognise that, but that's on us to make sure that we're maintaining that positive working relationship. Also, a bit of pushback from clinicians sometimes, who might feel like social care settings are not reliable partners in terms of accessing information. Again, part of my role I see as basically going out to bat for the social care providers and demonstrate. We've got audit data that demonstrates that actually they're accessing it in a really safe and sensible and secure way, and that's been a real part of my campaign. And then I guess the last bit is, how do we get this out to more places? I haven't even mentioned domiciliary care in all of this, or supported living, or day centres. How can we get them access? I am taking a paper to one of our regional boards fairly soon, making the case that we should test the water with domiciliary care, and actually, if it works well for care homes, it should also, if you can demonstrate the workflow and the benefit, it should work well. I know I'm going to run out of time, so I wanted to finish on one last thing, which is that I had a conversation, or I think me and some other people from one part of London had a conversation with a care provider group last week that runs nursing care homes, and one of the questions that they had was, isn't this, is it going to kind of replace people, was kind of the first part of the question, and also, is it going to lead to worse working relationships with clinicians in other parts of the system, because you're not having to pick up the phone and that kind of thing. So you have to pick up the phone less to your community local community pharmacy or hospital discharge team, because you can see the information in the London Care Record. That is true, that you have fewer interactions with them. But when you do have to pick up the phone, or when you do have to have a conversation with them, what it means is that you are armed with better information, and they know that you are armed with better information. And so the quality of the conversation that you're having is so much better. And we know this, whether it's discharge teams, pharmacies, ambulance crews, the information that you have in your hands as a care provider is so much richer that you're actually able to come into that conversation from a much more informed starting point. And that's the feedback that we get time and time again. in terms of kind of benefit to the workflow, benefit to the reassurance that staff can provide to residents and to families and that kind of thing. So I could probably go on for the rest of this webinar, but I'm going to stop now and I'll have a look in the chat. Yeah.
Thanks so much, Dan. Really, really good to hear that sort of real life example of sort of what you've done to date. And, I think the theme that's running through is that, we're certainly not there yet. There's a long way to go, but great to hear that there's some of those demonstrated benefits already sort of out there, already happening, and hopefully we can see that continue to grow and progress across the other sectors and areas. I'm now going to just reshare slides again, so just get those sorted. And we can then welcome Alex to the screen. So 2 seconds, because obviously my screen share has gone right the way back to the beginning. 2 seconds. Okay. Can everybody see those? Yeah, got a nod from Alex. That's a good start. Okay, so without further ado, Alex, I'd love to welcome you. So Alex is from Dorset Council, and he's going to put a slightly different spin on interoperability, thinking about acoustic monitoring and the project they've done in Dorset. So thanks, Alex. Welcome.
Thank you very much, Fiona. I'm Alex. Nice to meet you all. You're going to hear a lot of terms that Tommy mentioned during his talk. So next slide, please. I'm going to briefly talk to you about the acoustic monitoring project we did as part of the Digitizing Social Care program for Dorset. The program ran between 2022 and 2025. And as you sort of like became aware of from previous speakers, there was an incentive to get providers to change from paper care plans to digital ones. And for integrated care systems that exhibited high rates of DSCR adoption, specifically above 80%, they were offered the opportunity, to scale up other care tech related technologies. So Dorset was one of those regions. Our DSCR adoption is currently at around 90%, fluctuates a bit because providers enter the market, providers leave the market, providers change systems. But because we were clearly above the 80%, we were offered this opportunity and we decided to scale up acoustic monitoring. Next slide, please. Now, from the get-go, the purpose of the project was to reduce unwitnessed falls, improve nighttime safety, minimize intrusive checks, enhance sleep quality. And this being a funded project, we opted for a grant reimbursement model. So we wanted the adult social care provider to pay for the use and installation of the system and the accompanying software, and then we would reimburse them up to 10K per site for the first 12 months. Next slide, please. When designing this project, actually, we thought about interoperability from day one. So our expression of interest process looked specifically for providers that already had a DSCR in place. This was not a project or an opportunity that was going to be offered to providers who were still on a pen and paper basis, because it wouldn't make any sense. We wanted to extract the maximum benefits from the use of this system. So we wanted them to have a DSCR in place, and we were specifically looking for PCS or Nourish, because these were the two systems that Ally, the acoustic monitoring supplier, integrated at the time. Obviously, they needed to have the DSPT certification, something that Tommy kept on mentioning during his presentation. And the other thing that we also looked at was reliable Wi-Fi infrastructure and connectivity speed. So there was no point in installing a system if your Wi-Fi infrastructure was not up to scratch. Next slide, please. So we received 20 expressions of interest, but not everyone met the criteria. Some of the criteria that made people sort of like be excluded from this project were the connectivity criteria. They were using a different DSCR system, or the speed tests that we ran showed that the Wi-Fi infrastructure was not good enough. But to sort of cut a long story short, 9 locations proceeded to install the system. 2 decided to withdraw due to different expectations. And all the remaining 7 are now live. 6 have been signed off, and the last one is in the process of being signed off. I'm going to quickly run through the results of the project, being mindful of time, but overall they were fairly positive. So if we can go to the next slide, please, Fiona. To get the results, I designed a data gathering process. My plan was to sort of look at specific faults and other quality related metrics at the installation point, and then revisit with an end of project questionnaire 6 to 8 months down the line. And they ran into a bit of a problem because the data reporting period for the baseline was for the 12 months prior to installing the sensors, and the benefits reporting period was for a period of 6 or 8 months after reporting the sensors. Data had to be normalized, as I explain in the next slide. So this is the formula that was applied to ensure that we were comparing likes for likes and did not end up with massively skewed results. And I'm very happy to say that across each of the standardized false metrics we were tracking, we witnessed positive impact, as evidenced by the next slide. So overall falls were down by about 50%, unwitnessed bedroom falls roughly 60%, same for ambulance callouts. So you can see that the benefits we were tracking were kind of linked. If you have fewer falls, you're going to have fewer ambulance callouts and fewer hospital transfers, etc., etc. What we did find, however, was that there was an increase in the percentage of high risks of residents. But that we feel was primarily due as to better identification and not really something massively changing due to the installation of the systems. One of the homes that demonstrated an increase of falls is being reviewed internally by the provider. So it was flagged up by using the system. Very, very rich data from using this particular system. Next slide, please. In terms of some cultural insights, the provider started reducing their night checks, leading to better sleep quality. Everyone rated the system as being reliable, so that's good. And they rated the support from the provider of the system as exceptional and good, so there were no problems there. But as has been evidenced through interviews and conversations, the shift from routine checks, care homes tend to be on an hourly nighttime check routine, to a needs-based care intervention is kind of inconsistent. And there was also mixed feedback on the disturbance reduction for residents. Next slide, please. They all commented positively on the usage and the integration. But there were some barriers, right? So despite our best efforts to ensure that there was good Wi-Fi coverage, we came up across, simple things like not enough power sockets in the rooms. So you do look at interoperability thinking, it's going to be systems talking with each other, but there's sort of like limiting factors on the ground, which sometimes tend to be overlooked, which do not allow you to actually perform the intended project. It's nice talking about interoperability and what systems can offer, but we found that in certain cases, staff lacked the digital skills to be able to make proper use of the technology. There was also a strong cultural resistance to changing long-standing check routines. And at the time of running the project, there was also a very limited market in terms of acoustic monitoring technologies. I'm expecting more to enter the space and things will move forward, but this is a snapshot of where things stood 12 months ago. Next slide, please. So what did interoperability actually look in practice for this particular project? The systems did communicate with each other, which was the original intention, to have the Ally acoustic monitoring system feed data into Nourish or PCS. So this happened, right? There was no problems there. But managers did sometimes comment on the level of information and the detail passing from one system to the other. So a few managers were asking for richer data to be exchanged. Some other managers commented on the terminology used by one system when it was talking to the other, saying that this to an outsider might look as if we're not doing things properly. And to their credit, Ally did respond to these concerns and changed the language to better mirror the level of quality, the care being delivered. A key thing was that managers were confused as to, what is the ultimate source of truth? Where do I need to look for my false related data? Where do I need to look for to understand what's happening with my residents at night? Is it the care planning software or is it the acoustic monitoring software? They do talk to each other. Data flows from one system to the other, so from the acoustic monitoring to the DSCR. But where do I look? That was a question that kept on coming up. And this led to some skepticism. Yes, we have data being exchanged, but is it the right data? Is it communicated in the right language? Where do I need to look to understand what's happening with my residents and my night staff and the nighttime care routines? And this did create a level of cognitive overload, right? So managers and team leaders having to manage yet another system proved to be challenging sometimes. Next slide, please. So what we found from this particular project, technical integration and cultural integration are two very different things, right? You can technically integrate two systems, they will speak with each other, but for the culture to change, that's a completely different story. It is important to have one source of truth, and that is very important for care managers, for care recipients, for staff, for everyone. Cognitive overload is real. We keep on helping slash pushing the sector to digitize and adopt more systems and do things, but people working in the sector have limited headspace. There's only so much change you can absorb. Trust takes time to build. So you introduce a new system, it has wonderful new features, it connects with what you already have, your existing tech stack, but you're not going to trust it for a while. It does take time. And for data to be meaningful and for the interoperability story to be meaningful, it needs to tell a story very quickly, very visually, some perhaps, and very in a way that's easy to digest. Seeing spreadsheets upon spreadsheets of data communicating and trying to explain to managers that, look, the numbers show this doesn't really work. It has to be sort of like very, very easy to digest and understand. You need to be digitally ready. So you shouldn't venture into this space unless you are up to speed with your DSPT, unless you have a DSCR as a minimum, strong leadership, Wi-Fi infrastructure, the ability to engage your staff members, upskill your staff members, support them. And actually, if you do score a couple of quick wins, it is essential that you showcase them to your stakeholders, internal and external, because this will drive adoption and embed that interoperability a bit more. And as we found with this project, supplier partnership is critical. And I think I did see in the question box, how do you get suppliers to talk to each other and on interoperability? And I can answer that later on based on the experiences I have. Next slide, please. That's the end of it. Right on time, not overrunning. Well, thank you very much. Happy to take any questions from the audience if there are any.
Thank you so much, Alex. Really, really appreciate that. There's been a few popping through. What we're going to do is we'll pick them up in just a second, and we have a bit more of a chat and pick up questions. Just before we do that, I think I just wanted to sort of wrap up and say, we've had some really, really amazing examples there of sort of interoperability in action. And I think one of the things that I wanted to sort of circle back to was that slide back in Tommy's presentation right at the start, where it was sort of starting to really think about actually what can you do as care providers, because it's not perfect, it's not there. There's a lot of scope still down the line. Dan's alluded to that, Tommy, Alex. For example, in London, amazing work happening in care homes, nothing in dom care. But actually, how can you as a provider start to be prepared for that? And actually, it was really timely, Alex, that you finished on it too, actually thinking about, looking at your own internal systems. What have you got? Is it an assured system? Do your own internal systems, are they interoperable? Start looking internally first, maybe. Have you got the infrastructure, the staff skills to manage this change going forwards? And I think that's really important to start, making sure you're ready, making sure you can do whatever you can so that it's not then a massive thing, sort of further down the line when things become live in your area. DSPT has been mentioned many, many times. Hopefully you all know what it is. If you don't, it is an online self-assessment that helps you improve your cybersecurity. If you don't know, our organisation has loads of support available to help you complete that. So I will make sure we send all those links out with the slides. So if you haven't looked at your DSPT, if you haven't started it, I urge you to do so. If you have done it, I would also urge you to maybe look at the next step. So start thinking about how do you really embed that in your organisation so that it's not just a bit of a tick box and like, oh yeah, I've done that, which don't get me wrong, I totally understand being in that position. Like Tommy, I'm also from a clinical background and I've been in your shoes running services going, oh God, other thing I need to do, but really try and start thinking about embedding it in your organization and making it real in the way we do with other key themes within social care. And just to touch on neighbourhood health, massively important. Again, it's another thing that's similar to this topic, really, hugely variable, different in every area, not fully clear, sort of what's happening, how that's going to look everywhere. But, start finding out what's happening in your region, connect with your care association, try and make sure that as a sector you are represented in that conversation, and that might help you start to look at what that's going to look like within your area and help you be sort of more prepared. So just thought that was a nice sort of full circle moment to really think about what you guys can do as care providers. And I would sort of urge you just to take a few moments just to think, okay, what is my first step other than making a cup of tea, which I realised when I wrote this slide to start with, linked to interoperability, but what is that first step you're going to take? Is there actual real action that you can make sort of moving forwards? So I said at the start, we've got loads more stuff around interoperability on the website, so do take a look. This link will be circulated with the slides. So I'm going to stop there, and we are just going to circle back around and revisit now the Q&A that we've had so far. So I'm just going to stop screen sharing because you don't want to look at the horrible grey slide. Hopefully you can see people now. So I'm just going to work through the Q&A methodically. And Tommy, you've kindly answered the first question from Karen, but just for the benefit of everyone else, if you haven't looked, the question was, there is a requirement for all adult social care providers to record, update and share regional adjustments digitally, linking up with health systems from September 26. Has the regional adjustment digital flag been considered as a standard for assured digital social care records? And if you haven't seen Tommy's responses, that they're aware of it, talking to NHS colleagues, and it will hold the Assured Solutions Catalogue standard as part of sort of business as usual. So hopefully that's a reassuring response. Thanks, Tommy, for answering that. So next, we're going to go to Neil's question, which I think is aimed at Dan. But if anyone else has anything to contribute, please do. So maybe a question that you don't want to answer, but what difficulties did you face with getting system providers or vendors engaged and on your side? And how did you get over any obstacles? So actually, sorry, it says that's for all speakers.
Yeah, I was going to say it.
Hadn't quite read to the
bottom. Well, so I'm taking this question as twofold. So getting providers on board is one issue, and vendors of the SERs is another issue. And Neil, I hope that's okay, that's how I'm approaching it. So getting providers on board, we know from our local engagement that the best way to get them on board is that kind of one-to-one contact, picking up the phone, going for a visit, for a meeting to talk about might be a range of issues. So generally what's been really successful is that people in kind of more local bits of the system who have gone out to engage with care providers will go out and engage around the better security, better care, so completing their DSPT. And and whilst we've got you here, can we also tell you about the London Care Record? Can we also tell you about the Universal Care Planning? Can we also tell you about support for remote monitoring or acoustic monitoring, as Alex was talking about, platforms that we're able to support locally, and having that kind of all-in-one conversation. You build the relationship, you understand what their concerns are, and you can kind of address it much more easily that way. We also, us and our kind of local colleagues, go out to care home forums, networks, anywhere where there's likely to be care providers there that we can engage with. But generally, the feedback that we get is that kind of one-to-one engagement works better. Where the forums are coming into their own now, we've got kind of a baseline of providers that are already connected to the London Care Record. We can always start off those engagements, start off our agenda with hands up who's already got access to the London Care Record, and usually a handful of providers will put their hands up and will say, oh my god, it's changed our working lives, I can't imagine working without it. They might also have a few complaints about it, it's a bit slow to load, or this hasn't been working, but in that case, we can signpost them to the right place and make sure they get help. So that tends to be providers for the ones where they're a bit resistant. We'll follow up. We'll arrange a follow-up call. We'll arrange a follow-up visit. Whatever it takes, we can walk them through. Some of the bits of the process are a bit fiddly. They're not too difficult, but they're a bit fiddly. But let's help walk people through that process to get them through to accessing the London Care Record. In terms of suppliers, as I mentioned, we had to pay a development fee, so that is the initial hurdle, barrier to getting engagement. But again, like I said, once we paid it and the work is kind of done, it's no longer kind of the top priority for the suppliers, because they need to make more money from other things. So really it's about building and maintaining a relationship, whether that's kind of a monthly check-in, making sure when there's an event that we're at that the suppliers have got a stand, we go and build that, meet the team and speak to them. We invite them to a bi-monthly kind of delivery group meeting with people in our integrated care boards who do the engagement work, so they have an opportunity to hear how it's going that way. That's probably going to change in the next few weeks, but we'll still keep them informed that way. That's probably the key points from me on that.
Thank you, Dan. Alex, have you got anything to add?
Yeah, absolutely. In terms of getting people on board, right, while delivering the DISC program, engagement was constant. So I would be a regular feature in registered managers meetings. I would provide updates to the market. This is what's happening. This is how the assured supplier list was changing, because it started off with 8 software solutions in there, then jumped up to 17, went down to 13. But I was sort of like taking providers with me along the journey, showing them what systems were available at each time, bringing them updated data on how many people are actually using a DSCR within the Dorset integrated care system, tracking benefits. So I was feeding back on, these are some of the benefits that the existing providers are realizing. And I have to say that this constant effort of showcasing that the program is happening, the support is available, this is what you need to do, and this is, the money on offer, etc., plus the benefits story behind it. Your peers are reporting reduction in printing costs, a reduction in medication errors, staff efficiencies, all this sort of stuff. That drove engagement further. So that's key. An area where I did struggle, and that was a good learning experience, was when I had another social care provider who wanted to install a digital system. Let's call it digital system A, and they were using a DSCR. Let's call it system B, and he wanted the two to speak together. And I did facilitate a meeting between company A and company B, and they made it nigh on impossible to actually work together. And it never materialized. It never happened because the demands of the two companies on each other, I want to see this from your workload, and I want to see that from your workload, made everyone very skeptical in terms of disclosing business secrets. So that was a challenge I wasn't able to overcome, if that helps anyone.
Thanks, Alex. Really, really helpful insights. Okay, next one, Dan. We're back to you, and it sort of follows on from what you're just discussing. Really, John's sort of said that the your presentation was really interesting around London Care Records, but just trying to dig a bit more into actually why the uptake in social care is so hard. I don't know if you've got any insights, because you've given really good examples of sort of how you engage with the market, but actually maybe some of the whys would be useful to hear.
Yeah. So just to say that offline, I've emailed John, and we're going to have a chat about this to kind of delve further into it. But so thanks, John, for the question. But why uptake in social care is hard? Yeah, I think some of the things I mentioned. So like at different ends of the spectrum. So at the large providers, it's a bit of a headache for head office. At the small providers, it's a lot of kind of management time that they don't necessarily have to kind of get around to follow the steps and get connected. And I think, to kind of reference one of the other questions in the chat that now can't find, but the one about not working with digital natives. Like sometimes it is kind of, they're a bit worried that they won't understand what it is. They won't know how to use it, and so it's kind of providing some of that reassurance to say, actually, this is going to make things clearer, not less clear, and demonstrate that we can give demos, we can we can share videos of care home managers talking about how revolutionary it's been. We can share quotes from people. Like we've got all of that in supply, so we can do all of that essentially. And some people just don't want to. Some people just don't want to do it. And there are some care homes where we've gone, you know what, we've tried 15 times. Let's leave it. We might come back in 6 months' time and kind of send them a friendly reminder, but let's focus on the ones that we can persuade.
Thanks, Dan. Really helpful and useful for you to touch on the digital natives question as well. Alex, what did you want to add in?
I want to add to that digital natives question, because digital skills on staff members is a key factor that sometimes tends to get overlooked. And we came across it quite a few times while delivering the project. So what we did is we developed tools that could help adult social care staff members identify their digital gaps, be signposted to resources that already exist out there. So, the digital skills framework and the 7 themes associated with it. I'm going to put a chat in the link and you can access it and sort of see for yourselves. And as part of the program, we also helped managers to attend the digital leadership training provided by Skills for Care, in the thinking that if the manager gets upskilled, then they can sort of diffuse that knowledge within their staff team. But we equally also formed a digital champions group specifically for adult social care. So more than 30 people attended these sessions, and we helped them, guide them through completing the Skills for Care digital champions training for adult social care. I feel it played a key role in actually driving digital adoption within the sector. But yeah, not everyone is happy. And as Dan said, some providers said, no, we're not going to change. We like pen and paper. We're not going to change, There's only so much you can do.
Thanks so much, Alex. Okay, so just moving on to our next questions. So from a provider perspective, what should organisations be preparing for now to align with the next phase of interoperability, particularly around consistent, high-quality data recording within shared frameworks? And do you see that foundation eventually enabling more predictive or preventative system-level insight? I could just going to allow everyone to digest the question, but I wondered, Tommy, whether you might be able to come in there.
Hey Preet, nice to see you, or not see you, but hear your message. I've been thinking about this one for about 5 minutes because it's a really good question. I think it depends on how you answer this one. So I'm only one person. I would say we've moved beyond paper to really good care planning software and really good EMAR and really good rostering services. How connected are those to other devices around the Internet of Things world? The acoustic monitoring reference that Alex made, the pain check type technologies of this world, the more consumer care technology-based technology, how that connects to your system, I think is the next thing. And as well, I think the AI world of technology where it moves from transcription tools to transcription and decision-based making tools, and how integrated those are into your systems. As an aside, I'll get to the second bit of your question in a minute. I think the challenge around AI bit is we have lots of AI to help with decision making, but I think what we don't have is the traceability for decision within that. As in, so who made the decision? Was it AI or you? And if it goes to court, who made the decision? Although that doesn't answer wasn't part of the question, but I think it's connected to interoperability. And then in the second bit around, well, the government hasn't said a great deal about social care, unfortunately, but that's consistent, sadly. But we do know that we have the Casey Commission on the horizon and whatever that will say. And we do know that we have the National Care Service. And we do know that government is particularly interested in delegated healthcare tasks. So the second part of your question, if you've not got good quality data about activity of what your staff are doing, I ultimately don't think you can bill accordingly. And I don't think you can really represent the true cost of the care that you've potentially been delegated to do. So I think what would be great, wouldn't it be great if there was a national repository that said to government and policy and the NHS, the cost of delegated care tasks that you might want care providers and your care workers to do vicariously is actually going to cost this, this, and this. And here is the robust evidence and quality data that you referenced there to actually evidence that. Whereas at the moment, that will be piecemeal depending on the provider. And from a government's perspective, it's a real headache if certain providers have got good quality data and others don't. You get a really uneven picture. So there you go, well, I don't really know whether it's good data or not because you've got good data and you haven't. So I think a system level insight into understanding around activity, because I think delegated healthcare is just going to be more and more and more, and it isn't defined. Crucially, we don't have a definition of what is delegated and what isn't, so it's going to be a locally agreed. So if your data doesn't accurately reflect, then I think that's going to be a problem. But conversely, if your data is good and potentially interoperable, then you can evidence more transparently the actual cost of care, which is a better thing for a provider.
Thank you, Tommy. Nice response in the chat, just saying really good answer. So thank you for that. Alex and Dan, I don't know if you've got anything to add or happy to dodge that one and leave it to Tommy. Okay, good stuff. Okay, so quickly moving on, where we've got about 8 minutes, so we'll try and get through the final couple of questions. So I find that providers are working with all their data being fragmented across several systems, which I think we can probably all really relate to. Sometimes this data is easy to get back, and other times it's like a digital prison. Jamie's currently working with a dom care provider transitioning from paper to digital, and already it's quite messy and costly. What's your best suggestion for providers in this place so that they can be part of the solution rather than panic buying to meet legislation? Don't know if anyone's got. Oh, Dan's got his hand up, so we'll go straight in.
Yeah, and it was just going to be to say that actually our team and your team are having conversations about this kind of area, where basically it's an absolute minefield, isn't it? What systems to procure, how to make decisions based on what systems to procure. You go to, say, the care show, and it's basically the care tech show, and you're not comparing apples with apples, you're comparing apples with pears, and there's so many different variations of products where one company at one stand will have 4 identical products to the company next to them, but then there'll be 2 or 3 elements within their products that are different, and so you can't quite make a direct comparison between them. It's really confusing, and we've heard that directly from care homes and dom care providers and supported living providers, from everyone. We started a piece of work kind of pulling together. There are loads of different bits of guidance from there's a London ADAS guide, there's Skills for Care guides, there's NICE, they're not Institute of Care and Excellence, loads and loads of different bits of guidance pulling together how to make some of those decisions, and that in itself is also really confusing because there's 17 different bits of guidance. So one of the things that we're talking to Digital Care Hub and Skills for Care and other organisations about is how can we kind of pull out the key messages from all of those. Is that going to be across a couple of webinars, or speaking on podcasts, or whatever it is. So we're hoping to get that out fairly soon.
Thank you, Dan. Alex or
Yeah,
Tommy, anything to add? Yeah, Alex.
I can add a thought to that. For providers who are navigating the process now, right, reach out to your peers. There's providers, networks, and forums in your local area. Ask to be linked in to somebody who's using the system that you're exploring. They'll give you far better feedback on its usability, features, good things, bad things, bugs, whatever it may be, than a sales demo will. So that's my advice to you. And the other thing is, when somebody approaches you and pitches the software to you or the solution, you have to keep in mind that these are products that are built for the majority of the market. So these are not custom built solutions that are never gonna in reality map out 100% of your workflows. So some level of compromise will need to come from your side as well. And you can ask them very open questions. What is the data extraction policy if I do need to move out? I do need to change system. What can I take with me from platform A and go to platform B? That's my experience over the last 3.5 years.
Thank you, Alex. Really helpful. Tommy, anything to add?
Well, if you're only using 20% of the product, if I were Access or Carebury, I'd be going, well, that's only 20% of the functionality we've pumped X number of money into to get this to work. So I don't know what their customer success, I don't really like the phrase customer success, but that's often what the teams are called, would have to say on that, Jamie, because a well-functioning system is in the benefit of everybody. Yeah. And if you're going to go custom built, Jamie, as I've said, build your own is fine, but you're not in the game around standards and of interoperability nationally. That's not to say you shouldn't do that, by the way, because off the shelf doesn't represent everyone's nuanced perspectives. So if they are building their own, or someone is, do look at the standards on the Digitising Social Care website, because interoperability won't work if you're not using standardised tools.
Thanks, Tommy. Yeah, really, really sensible consideration. And Jamie, I don't know if this is helpful, but the end of January, we actually did a webinar looking at sort of innovation within the sector, and we covered a couple of care providers who had built their own systems, and these were some of the sort of cons, I guess, that we covered around. Obviously, bespoke brings other benefits, but actually the downside being the sort of standards and interoperability side. So feel free to sort of go back and look at that. The recording is available on our YouTube channel if that's helpful. Could always put you in contact with those providers. I'm sure they would chat with you. Okay, I'm aware we have literally 3 minutes. So is there a separate work stream looking at engaging with providers who don't have DSP/DCR and who are in real danger of being left too far behind? I understand there are various reasons. I mean, I can definitely answer that from a DSPT perspective, is that's exactly what our programme is doing. So at the Digital Care Hub, we have a huge support programme nationally trying to get providers to complete their DSPT and throwing lots of personalised one-to-one support with that. Tommy, I don't know if you've got anything to comment on the DSCR side.
The answer is no. It's your decision whether you want to have a DSCR or not, whether you can afford one, whether you can, what you choose. It's entirely up to you. Care providers are private individual businesses. It wouldn't be the role of central government to say you have to have one and it ought to be that, unless they were changing legislation or so on and so forth. So from a DSCR perspective, there was funding available, not anymore, but the market is available. If you wanted to get something, get something. If you don't. Whether a provider is left behind or not is entirely a subjective term. It's entirely their call, really. But I think the benefits are very obvious, and there are some very good products out there.
And I was going to jump off the back of that and kind of link to one of Alex's previous answers, which is, BSBC is being run by care associations locally in your area. So connect with your local care associations, because you'll probably be able to have some of those conversations, and like Alex said, with other care providers that have gone down the road of, different DSCRs. And you can kind of have that comparison chat and find one that works for you through that route.
Thank you, Dan. I'm really mindful that we're on 29 minutes past and we will literally get kicked off the call at 1:30. So we've got one question left from Clive. But what I'll do is I'll send a written response to that, because it's a slightly more straightforward one around DSCR. So we can pick that one up. So thank you all so much. Like I said, I'm mindful we will get kicked off. So thank you for your time. Just to clarify, big thank you to our speakers. You've all been fantastic, great conversation. You'll get a copy of the recording and all the slides and any other resources that we think are useful. So keep an eye on your inbox over the next couple of days, and we'll catch up with you all soon. Thank you so much, guys. Thanks then. Bye bye.